Now about the genetics, since it's a multifactorial inheritance, it has to do something with the genes, and then the environmental and the environmental influences, and the lifestyle of the person and the occupation of the person. They all come into play, and asthma. They play the role in causing asthma. So more than 22 loci on 15 chromosomes, they have been linked to the asthma. Like it has very variable um, inheritance. It, asthma has been consistently linked with loci containing pro-allergic, pro-inflammatory genes, like for uh, genes, and they have clusters. It's a member of metalloproteinase family, and the gene located on short arm of chromosome 5. Quite severe pneumonia, recurrent pneumonias in infantile ages, bronchiolitis requiring hospitalization, wheezing in the child apart from the common cold. In smaller children, wheezing can be there as part of the common cold, but wheezing um, without colds, it can be considered as one of the risk factors. Then male gender, low birth weight, environmental tobacco, smoke exposure, reduced lung function at birth. Asthma productive children, major criteria: parent asthma, eczema, rhinitis, wheezing, food allergens, and eosinophils more than 4%. Types of childhood asthma. There are two main types of childhood asthma: recurrent wheezing by common viral infections of the respiratory tract. Then the other one is the chronic asthma associated with allergy that persists into later childhood and often adulthood. So basically, there are two types: recurrent wheezing in early childhood, usually due to acquired viral infections. In chronic asthma, usually with atopic allergies. Sometimes the third type of childhood asthma occurs in the females who develop obesity and early onset puberty by the age of 11 years. But this is not very common. Now, what causes the asthma? What happens in asthma? What happens to the lung and windpipes and air spaces in the asthma? The airflow obstruction in asthma is the result of numerous pathologic processes. In the small airways regulated by smooth muscle encircling the airway lumen. So bronchoconstriction of these bronchial and muscular bands, it restricts or blocks the air. Cellular inflammatory exudate, eosinophils and other inflammatory cell types, which includes neutrophils, monocytes, lymphocytes, mast cells, basophils, they can fill in and physically obstruct the airways and induce epithelial damage and peace formation into the airway. So the one is the bronchospasm, or the spasm of the smooth muscles encircling the smaller airways. The second is physical obstruction of the airways by cellular inflammatory exudate. So the both do the same thing. They prevent the passage of air from the smaller airways and can cause bronchoconstriction and all the symptoms associated with this bronchoconstriction of asthma. So the same, the helper T lymphocytes and other immune cells that produce pro-inflammatory cytokines, interleukin 4, 5, and 13, and chemokines to mediate the inflammatory process. So airway inflammation is usually linked to hypersensitivity of the airway smooth muscles to numerous provocative exposure that act as triggers, as well as airway edema, basement membrane thickening, subepithelial collagen deposition, smooth muscle and mucous gland hypertrophy, and mucus secretion, all processes that contribute to airflow obstruction. So what happens in asthma episode, whenever there is a trigger occurring in the patient, some inflammatory cells physically obstructed, smooth muscles constrict the lumen, and resulting in airflow obstruction. Now, some points about the asthma trigger. Okay, what causes the trigger of asthma? So the common viral infections are one of the leading cause of triggering asthma attack. Then aeroallergens and sensitized asthmatics, animal tender, indoor allergens like dust, mites, cockroaches, molds, seasonal aeroallergens like pollens from trees, grass, weeds, environmental tobacco smoke, air pollutants, like ozone, sulfur, wood, coal burning, smoke, some endotoxins or mycotoxins, dust, strong or noxious odors. Sometimes you must have seen asthma gets triggered with very strong odors like perfumes, like hairsprays, like certain cleaning agents, or certain insecticide sprays as well. Some occupational exposures like farm and barn exposures, formaldehydes, which has again a very strong odor, paint fumes, again a very common trigger of asthma. Sometimes cold air and dry air, they are also linked, extremes of the temperature, they are also linked to as a trigger of asthma. And exercise can also induce asthma. Hyperventilation in smaller children, excessive crying, or like extreme of the emotion, like excessive crying or excessive laughter, can sometimes trigger the attack of asthma. Now, some comorbid conditions like rhinitis, sinusitis, and gastroesophageal reflux disease, these all are considered as asthma triggers. Now come to the clinical manifestation and diagnosis. How would the patient come to you? In which you have to think of asthma. So the coughing, intermittent dry coughing is one of the common symptom of asthma. Patient, smaller children may not complain of chest tightness, the characteristic adult-like symptoms, the chest tightness and wheezing. They may come to your clinic with complaint of dry coughing. Nighttime cough is one of the symptom of asthma. And expiratory wheezing, if the child is older enough, so they can present you with the wheezing. It is again one of the persistent wheezing is one of the common chronic symptom of asthma. Older children and adults will report with associated shortness of breath and chest tightness, the classical symptom. So if the child is older enough to report these symptoms, they may come with the complaint of shortness of breath with exertion or with climbing the stairs, or sometimes if it's uncontrolled type of asthma with minor of the activities, it can present with shortness of the breath. And all those symptoms, whether the cough, the chest tightness, or wheezing, they are usually more severe at night due to the diurnal response of smooth muscles. The tone is generally increased at night. Daytime symptoms, however, often linked with physical activities or play, are reported with greatest frequency in children. Other asthma symptoms in children can be subtle and non-specific, which include self-imposed limitations of physical activities. Like the children, they themselves, they stop doing the things which is bothering them. Like they stop playing, they stop running, they stop exertion, they stop climbing the stairs. So this is self-imposed limitation of physical activities due to the underlying pathology of asthma. General fatigue, possibly due to sleep disturbance, because as we know, all the symptoms are so severe at night. So if the child keeps coughing at night, if the child has recurrent wheezing at night and shortness of breath at night, the child may not sleep well and will be fatigued in the daytime. And especially social isolation, difficulty in keeping up with the peers and physical activities, difficulty in coping with them in playing and all those physical activities. What we have to do, we have to ask about the previous experience with asthma medications like bronchodilators. That can be a leading sign. It may provide a history of symptomatic improvement with treatment that supports the diagnosis of asthma. So recurrent, the shortness of breath or expiratory wheezing, improving with bronchodilators is one of the option that is favoring the diagnosis of asthma. So lack of improvement with, on the contrary, lack of improvement with the bronchodilator and corticosteroid therapy is inconsistent with the underlying asthma and should prompt more vigorous consideration of asthma masquerading condition. What are asthma masquerading conditions? These are the conditions, these are the diseases and symptoms which do present with asthma-like symptoms, but their pathology is different. And environmental history is essential for optimal asthma diagnosis and management. The presence of risk factors such as history of other allergic conditions like allergic rhinitis, allergic conjunctivitis, atopic dermatitis, food allergies, parental asthma, and symptoms apart from colds support the diagnosis of asthma as we have discussed before. Clinical manifestations and diagnosis. During routine clinical visits, children with asthma clinically present without abnormal signs. Okay. Some may exhibit a dry persistent cough, and apart from that, usually they have minimal signs. The chest examination is often unremarkable until and unless the patient is in acute exacerbation. However, in some children with deep breaths, one can sometimes elicit undetectable wheezing, which is called an expiratory wheeze with deep breathing. So in clinics, quick resolution within 10 minutes or convincing improvement in symptoms and signs of asthma with administration of short-acting beta-agonist, albuterol or salbutamol. It is supported for a diagnosis of asthma. And during acute exacerbation, there will be the finding would be expiratory wheezing and prolonged expiratory phase. And sometimes discrete breath sounds can be found in some of the lung fields, commonly the right lower posterior lobe, because of hypoventilation owing to airway obstruction. Sometimes crackles or rails in bronchi are heard. They are not due to infections. They are usually resulting from excess mucus production because of the inflammatory cells and inflammatory exudate of the airway. And when the air passes through these mucus productions and inflammatory exudates, the combination of segmental crackles and poor breath sound can indicate lung segmental atelectasis that is difficult to distinguish from bronchial pneumonia and can complicate acute asthma management. The greater the extent of airway obstruction causes labored breathing and respiratory distress, manifested as inspiratory and expiratory breathing, increased prolongation of exhalation, poor air entry, supraesternal intercostal traction, nasal flaring, and accessory respiratory muscles. So the milder the exacerbation, if airway obstruction is so much, the patient will start using accessory muscles of the respiration. We'll have supraesternal intercostal sections, which are retraction, which are not normally present in a normal system. And in sometimes at the extremes of the symptoms, we do not find anything. That is called silent chest. But that is not due to the fact that there is no wheezing there, but because of the reason that wheezing is so severe that it has almost completely obstructed the airways and the passage of the air, constructed airways, and that is the stage where the patient has reached the stage of impending respiratory failure. Now, some differential diagnosis of the asthma. There are so many respiratory illnesses that can be kept in the differential diagnosis. For some, it is sinusitis, adenoidal or tonsillar hypertrophy, nasal foreign body, then laryngotracheomalacia, laryngotracheobronchitis, laryngeal webs, cyst or stenosis, vocal cord dysfunction, vocal cord paralysis, tracheoesophageal fistula, some vascular rings or strings, external, sometimes external mass like some tumor compresses the airway. Foreign body aspiration can also obstruct the airway and can cause wheezing. Chronic bronchitis from environmental tobacco smoke exposure, and some toxic inhalants. And again, some lower respiratory tract infections like bronchopulmonary dysplasias, chronic lung disease of the preterm infants, which present with persistent wheezing later on in life, viral bronchiolitis in children, GERD, gastroesophageal reflux in children can also cause wheezing. Some causes of the bronchiectasis like cystic fibrosis, chronic aspiration, immotile cilia syndrome, and there is a long list. Which can be included in the differential diagnosis of childhood asthma. Now, we are done with the symptoms and signs. We have done the clinical examination. Now, the lab findings. We cannot label how to label asthma in laboratory, and we are going to see now whether the laboratory test will help us in diagnosing asthma or not. Lung function test can help to confirm the diagnosis of asthma. It is very helpful as an objective measure of airflow limitation. But it has some limitations also. Okay, some knowledgeable personnel are needed to perform an interpreter strap spirometry test. Secondly, the child should be cooperative enough. Third, the child should be old enough. It is usually said that spirometry is usually not helpful under 6 years of age because the children cannot follow all the commands. So reproducible, valid spirometric measures are dependent on a patient's ability to perform the same thing. Okay, more than 6 years of age. Reproducible spirometric efforts are an indicator of test validity. If on 3 attempts, the FEV1 is forced expiratory volume in 1 second, is within 5%, in the highest FEV1 efforts of the 3 is used. We repeat the procedure thrice, and the highest of the 3 findings is used as a reference. Because of its effort dependence on reliable spirometry testing. Now, what lung function abnormalities will we find in spirometry? We will find airflow limitation. Low FEV1 means low the fractional expiration volume in 1 second is low in a patient because of expiratory wheezing and bronchoconstriction of the lung. Now, there is another thing that we take FEV1 by forced vital capacity ratio. FEV1 is forced expiratory volume of 1 second divided by forced vital capacity ratio. If it's less than 0.8, so that means it's the obstructive pathology is there. Then bronchodilator response to inhaled beta agonist. Improvement in FEV1 of 12%, more than 12%, or more than 200 ml. So you are seeing a patient with bronchoconstriction. You do the FEV, you give a bronchodilator challenge, and then you repeat the FEV. If force expiratory volume in 1 second, if it's more than 12%, that meaning the presence of asthma. Mm, there is another thing that we can do is the exercise challenge. What we observe, we again observe FEV1, but here after we take the FEV measures, we do the spirometry, ask the patient to exercise, and then we again measure the spirometric values. So if worsening in FEV1 of more than 15%, that is also suggestive of asthma. Daily peak flow of FEV1 monitoring is for day-to-day monitoring in an AM to PM variation. If that AM to PM or day-to-day variation is more than 20%, again one of the factors pointed towards the presence of asthma. Now, bronchoprovocation challenge, it can be helpful in airways, as we all know, are hyper-responsive and therefore more sensitive to inhale methacholine, histamine, cold or dry air. So the degree of airway hyperresponsiveness to these exposure correlates to some extent with asthma severity and airway inflammation. But usually in pediatric age group, this methacholine or histamine challenge test is not done. Although bronchoprovocative challenges are carefully dosed and monitored in investigational settings, their use is really practical, as I said, in a journal practice setting. So in pediatric age group, we rarely do methacholine. We do diagnose the asthma clinically. So what is this exercise challenge test? Aerobic exertion or running for 6 to 8 minutes can help to identify children with exercise-induced bronchospasm. Although airflow response is non-asthmatic to exercise, what happens in non-asthmatic? Whenever they exercise, they increase the functional lung volumes and improve FIV1 slightly, like 5 to 10%. But what happens in asthmatics? It often provokes airflow obstruction in inadequately treated asthmatic. So accordingly, what happens? FEV1 typically decreases during or after exercise by more than 15%. The onset of exercise-induced bronchospasm is usually within 15 minutes after a vigorous exercise challenge and can spontaneously resolve within 30 to 60 minutes. But sometimes exercise challenge can induce severe asthma exacerbation. So one should be prepared for this severe asthma exacerbation if you are doing exercise challenge test. So we have to carefully select the patient for exercise challenge test. And there is another theoretical option. Exhale measurement of exhaled nitric oxide, which is a marker of airway inflammation in asthma and can help titrate medication and confirm the diagnosis of it. But we again not widely clinically used. Peak expiratory flow monitoring device provides a simple and inexpensive home use tool to measure airflow and can be helpful in a number of circumstances. Poor perceivers of airflow obstruction due to asthma can benefit by monitoring PEFs daily to assess the objectively airflow as an indicator of asthma control. Like there are some people who don't know that they are getting hypoxic. So in that daily peak expiratory flow monitoring, it would be helpful to monitor their symptoms and then and also to adjust their therapy. So peak expiratory flows, they vary in their ability to detect airflow obstruction. In some patients, peak expiratory flows decline only when airflow obstruction is severe. So this is the reason it should be started by measuring morning and evening. It has to be best of the 3 attempts for several weeks for patients to practice the technique to determine a personal best, because for everybody's peak expiratory flow will be different. So we need a prolonged time period to assess what is that personal best, and we decide their deterioration on the basis of their personal best. So peak expiratory flow variations of that person, more than 20%, is consistent with asthma. Now, radiology, when you go for chest X-ray, often appears normal, aside from subtle and non-specific findings of hyperinflation. Hyperinflation के findings क्या मिल सकती हैं हमें? There can be flattening of the diaphragms. There can be air trapping within the lungs. The lung fields appear more black and from peribronchial thick. अच्छा, although the chest radiograph cannot be used to diagnose asthma isolated, but it is helpful to rule out asthma masqueraders. Like it is important in ruling out other conditions that mimic the like aspiration pneumonias, hyperlucent lung fields in bronchiolitis, obliterans, complications during asthma exacerbation, like sometimes the atelectasis, pneumomediastinum, pneumothorax. Okay, now comes the management of asthma. Core components of optimum asthma management: regular assessment and monitoring. Asthma checkup should be done every 2 to 4 weeks until the good control is achieved. 2 to 4 per year to maintain good control. Daily lung function monitoring. Control of factors contributing to asthma severity. Eliminate or reduce problematic environmental exposures. Treat comorbid conditions like rhinitis, sinusitis, gastro-GERD, and then asthma pharmacotherapy. There are some long-term versus some short-term therapy medication. And then classification of asthma severity for anti-inflammatory pharmacotherapy. And then we should know the step-up and step-down approach. Asthma exacerbation management. It also includes patient education, very important, because until the patient is willing, we cannot treat asthma successfully. Daily management and action plan for a given action plan for asthma exacerbation. See, now the classification is usually beyond your level, but generally the asthma is divided into intermittent and persistent forms. Now, the intermittent is that form in which the symptoms occur less than 2 times a week, and then there is persistent. Persistent is again divided into mild, moderate, and severe persistent. Severe persistent is the severest form of the asthma, in which the patient needs to be, what we usually do, we usually start treatment with highest of the management. And if the asthma is there, like severe persistent asthma is that asthma in which the patient has daytime symptoms daily, also has nighttime symptoms daily, and the daily activities of living are severely impaired. So in which the patient needs daily medication, the patient needs high dose inhaled corticosteroids and long acting inhaled beta agonist. And sometimes we give corticosteroids tablets for shorter duration oral. Then the step 3 treatment is for moderate persistent asthma, in which the condition is better as compared to the severe asthma, but the symptoms are there every week. So the preferred treatment will be low dose inhaled corticosteroids and long acting beta agonist. Or we give medium dose inhaled corticosteroid, sometimes low dose inhaled corticosteroids, and with mast cell stabilizing agents. The mild persistent asthma is that asthma in which the patient has symptoms of persistent asthma. It's there for a long time, but the symptoms are mild. So what the preferred treatment for mild persistent asthma is low dose inhaled corticosteroids with nebulizer, usually, or metered dose inhalers with the spacer for smaller chili. And alternative treatment can be cromolyn or leukotriene receptor antagonist. But for mild persistent asthma, the preferred treatment is low dose inhaled corticosteroids uh, without long acting beta agonist. For moderate persistence, it's either low dose inhaled corticosteroid with inhaled long acting beta agonist or medium dose. And severe persistent, the patient usually need either high dose or sometimes oral can also be used. Now, the step one is called intermittent form of the asthma, and it usually gives quick relief for all patients. Bronchodilators with this one is the short acting is needed for symptoms. Intensity of treatment will depend on severity of exacerbation. The preferred treatment would be a short acting beta agonist by nebulizer or face mask. Uh, Sometimes we use alternative treatment if the inhaled beta agonists are not present. So in that, we can give oral beta 2 agonist. And if there are viral infections, we have to treat that also. And if the symptoms are at any stage, if the symptoms are not improving with local treatment, like inhaled treatment, we should add for oral corticosteroids, like systemic corticosteroids. We review what we do, we assess the patient severity, we start the treatment, and when we review the patient after every 1 to 6 months, and if we think that the symptoms are improving, we have to step down the treatment. Like suppose you have started a patient's treatment on step 3 and the patient has come back to you after a period of 4 to 6 weeks and there were no nighttime symptoms, there were no daytime symptoms, then we'll step down the therapy. We'll step down from 3 to 2. But again, if you are again assessing the patient and you see that the symptoms are not improving, then we have to step up the treatment. Along with that, stepping up and stepping down, we have to review whether the patient is compliant. We have to check about their environmental control. We have to check about their general attitude, their lifestyle, and all those things come into the play. What is the goal of the therapy? The good control is set when the patient is on treatment and has minimal or no chronic symptom day or night. The patient has minimum use of short acting. For all the acute exacerbation, we give short acting beta 2 agonist and we ask the patient to document the exacerbation. So a goal on any treatment is minimum use of short acting beta 2 agonist because they are called rescue medicine. Minimal or no exacerbation, no visits to the ER, minimal or no adverse effects from medication, and no limitations of daily activities, no school parents work missed. Now there is a list of some medicines of choice, which is I think beyond your level. So with this, we come to the end of